So when patients come in and they have arthritis, there's usually a whole spectrum of severity. Sometimes it's very mild and we're seeing them very early on in the process. Other times they come to us and it's already very advanced bone-on-bone arthritis. They're not having much function with that hip or that knee. They have decreased in their ability to move it and they're not walking very well. So we really treat patients individually, and it really depends on what part of that spectrum that they are on when they come to see us. When they're early on, there's lots of things that we can do before a joint replacement surgery, which is really the end of the road. There's things that we can do with regards to injections, with medications, with rehabilitation, and different conservative management, also with braces we can sometimes use. When it comes to a point to where the arthritis has gotten to where it's bone-on-bone arthritis, to where some of these conservative treatment options are not helpful any longer, oftentimes the only solution at that point is a joint replacement. So from a surgeon's aspect, the anterior approach is also very nice in that it allows me to have certain tools that typically you don't have in the operating room or as easily accessible when you're doing surgery from the posterior approach. One is that we have a x-ray machine in the operating room that we can easily position to get real-time and very good and accurate views of the hip and pelvis during surgery. This allows for a couple very important things. One is that we can fit components exactly the right size for each patient. Now you can do that with the posterior approach, but it's all on feel and there's no real good x-ray view to verify that or to give you a second view of that. So I think the benefits of the anterior approach are multiple, from the quick recovery or quicker recovery of patients to their getting their function back and being able to go back to their everyday life, to the things that help me as a surgeon in placement of implants and making sure that they're exactly how I want them and that they're positioned correctly, and the effect that this has on the longevity of the implants I think are very important and keys to the anterior approach. At this point, 100% of my primary or first-time hip replacements are done through the anterior approach, and a significant amount of revisions or second-time surgeries when we have to do that for any type of complication, is whether that's just the longevity of the implant has reached the end or that there's other complications, or sometimes injury from a fall causes a complication that we have to do a revision. And at this point we're doing a significant number of our revisions from the anterior approach also. So after a joint replacement, whether it's a hip or a knee, our goals are really to allow patients to get back to the things that they want to do. Sometimes they want to take their kids to Disney or their grandkids to Disney World, or they want to hike, or they want to do all of those activities that they used to. Nowadays we have lots of patients who into their 50s, 60s, and 70s are still going to the gym, they're still very active, and they want to do all these things. They want to ski, they want to play sports, and they want to continue to be involved. And a hip replacement and knee replacement surgery, we really do that to help patients take care of the pain of arthritis, but secondarily we want them to get back to their activities of daily living. And sometimes their activities are more than just the typical things that you want to do around the house. They're very active and with sports and different other activities. And for my patients, I want them to do all of those things.